The American Diabetes Association is leading the charge against the deadly consequences of diabetes and fighting for those affected. As more than 12,000 leading physicians, scientists, and healthcare professionals from around the globe come together for the world's largest diabetes meeting, ADA TV is here with all the highlights. Welcome back to ADA TV. I'm your host, Autria Godfrey, and today we are turning to innovation in diabetes care. As technology moves at an incredible pace, we're taking a closer look at the new ways innovation is giving a boost to the fight against diabetes.
AI is a black box. We don't know what's going on inside.
Straight ahead today, the role of AI. It's the hot topic in medicine today. We are sitting down with one expert to discuss how using artificial intelligence can be key in diabetes treatment.
As long as profits are driving our decision-making around the preservation of human life, we will fail.
Plus, our first debating diabetes segment. When it comes to innovation, what should we prioritize? Our two doctors weigh in.
Couldn't find any software that went into the detail and user-friendliness of deep nutrition data, so I ended up building it for myself.
And there's an app for that. Wait until you see the new way your cell phone can play a role in nutrition management. So much to see here on ADA TV and so many ways for you to watch. You can always find the latest ADA TV episode on our TVs placed throughout the convention center, on the in-house channels at several of our partner hotels, on the shuttle buses to and from the venue, on the ADA Scientific Session website, and on our X and YouTube pages. Let's get to it. Dr. Alice Chang kicks things off with what you can find happening today at ADA. Dr. Chang?
Thanks, Autria. Saturday is going to be an exciting day of learning and sharing. In the morning, bright and early at 8 a.m., there'll be a number of symposia that will satisfy everyone's different interests. For me personally, I'll have a tough time deciding between the Select and the Inhale 3 symposia. In the Select symposium, new data looking at glycemia, inflammation, and heart failure will be presented. At the same time, the results from the Inhale 3 randomized trial of inhaled insulin versus automated insulin delivery, or MDI, in type 1 diabetes will be presented. This is when a clone would be super helpful. The special lectures and addresses are always inspirational, which will start at 9:45 a.m. We will hear from Patty Urbanski on diabetes education for one and for all, as well as from Dr. Joshua Newmiller, the deserving recipient of the Outstanding Educator in Diabetes Award, at 10:45 a.m. At 1:30 p.m., I look forward to a debate entitled Innovation or Access in Diabetes Technology: What should be our global priority? At 3:15 p.m., there's an exciting panel on the very hot topic of GLP-1 plus or minus GIP receptor agonists in the perioperative setting, to stop or not to stop. That is the question. Then at 4:30 p.m., backed by popular demand, is the Innovation Challenge, where candidates will have an opportunity to pitch their novel, innovative idea to potential funders, and we, the audience, will get to vote for the best idea. Fantastic audience participation. And as always, throughout the day, there will be exciting oral abstract and e-poster presentations. Lots to look forward to on Saturday.
How will artificial intelligence change diabetes clinical practice? That's the topic being discussed during our Ask the Expert session, and one of those experts, Dr. Boris Kovachev, is here in studio now to weigh in. Pleasure to have you today.
Thank you for inviting me.
Absolutely. This is such a hot topic, truly across medicine as a whole. But I want to start simple. Can you lay out some of the ways that data is being aggregated or mined when it comes to diabetes?
Well, AI is used in several ways in diabetes. One of the most popular ways currently is to use large language models and GPTs to aggregate data, produce new content, summarize existing knowledge, and digest it for the physician or for the individual with diabetes. But the real difference in diabetes is in continuous glucose monitoring. That's the only disease, I believe, that has that kind of monitoring every few minutes, and that generates enormous amount of data where AI is very, very helpful.
You've said in the past that the physician will play interpreter when it comes to utilizing AI. So how do you see the clinician using AI in the clinical setting?
Well, not just an interpreter, also a decision maker. But AI will summarize things, will find subtle relationships in the data that people cannot see with the naked eye. For example, in CGM data, there is a cloud of traces that the naked eye cannot really distinguish, and AI will predigest that to a meaningful piece of information provided to the physician, and then the doctor makes a decision based on that digested information. It just the data is so much now that the human mind is incapable in digesting it in a short encounter between physician and the patient.
You also think that AI will have an impact on clinical trials, or rather the data that we get from clinical trials, correct?
Yes, I mean the data that we get from clinical trials currently are generally simple, hemoglobin A1C, things like that. But when continuous monitoring comes in, the clinical trials generate a lot of data at once. So there is data science needed to process this data and find meaningful outcomes from the clinical trials.
Are there any downsides to AI? There are some ethical concerns. What do you say?
There are concerns with AI at several levels. The most intriguing thing is that AI is a black box. We don't know what's going on inside. We don't know when we get the data in and we get an output from AI, we don't know how this is processed inside. It's a matter of the training of AI. So if we didn't train it well, it can go anywhere.
Right.
And that is of a concern, not just for the physicians, but also for regulatory agencies as well.
Is it also a concern making sure that we have data from diverse populations?
Yes, it has to be diverse, it has to be comprehensive, it has to be in different situations, corner cases and so forth, because that's where AI will fail. If it hasn't seen something, then it may fail.
Final question for you, and I think this is kind of the million-dollar question when it comes to AI. For both the physician and the patient, they want to know, will machines replace my doctor?
The machine is not going to replace the human touch, but it depends on what do you mean replacement. If we go with the Turing test that says a machine will pass for human if it convinces other humans that it is a human, then that is already happening. For example, I'm going to review today a paper briefly that came out of Israel in January, and GPT-4 passed the residency exam in 4 out of 5 specialties over there. So it's unclear. There is some concern there.
Right. It'll be interesting to see what the future holds with regard to AI.
And it's not too distant future either.
Right, we're there.
It's happening now.
Dr. Kochev, thank you so much for your time today.
Thank you.
Appreciate it.
Thank you for inviting me.
Turning now to Twin Health. The revolutionary whole-body digital twin offers precise, personalized guidance on food, sleep, activity, and breathing through an intuitive app. Take a look at how Twin Health delivers tailored recommendations to help members achieve diabetes remission.
Digital twin is a digital replica of a person's metabolism. With that information, it can understand where the metabolism is working well and tells the person what to do to make it work better. And as the person's metabolism functions better, many diseases reverse.
At Twin, our technology is a combination of very unique sensor data and also our digital twin AI. We are able to generate very unique and individualized insights and recommendations that help each member get to the most optimal health outcomes.
After 6 months of engagement, twin members experienced incredible clinical outcomes. For those with a hemoglobin A1C starting greater than 8, we achieve an average of 2.3 points of reduction in A1C. 71% of our members are able to eliminate a high-cost medication and sustain that elimination for extended periods of time.
To another app empowering patients with long-term conditions like diabetes. Chronometer is the most accurate, comprehensive nutrition tracking app. By utilizing nutritional data and with the integration of Dexcom, it's no question why more than 9 million people are improving their health through the Chronometer app. Check out how it works.
Chronometer is an app that I originally developed as a hobby, starting way back in 2005. I was wanting to nerd out on my nutrition and the diet I was doing at the time, and I couldn't find any software that went into the detail and user-friendliness of deep nutrition data. So I ended up building it for myself. We've recently passed 9 million signups, and that includes both consumer signups with the app in the App Store, as well as clinicians and doctors, dietitians, research institutions, hospitals that are also using us in clinical settings.
We offer tracking on all micronutrients, which are vitamins and minerals, which really gives people a more holistic view of their health. And I honestly believe that anyone who uses our app is going to benefit. There's absolutely no downside to tracking your nutrition. The things that people can learn about their health, their nutrition in general, can really, I believe, help them live longer, fuller, happier lives.
Turning now to our first debate in diabetes, and today we are posing the question about technology and what should be the global priority, innovation or access. Here to weigh each angle is Dr. Apoorva Gomber and Dr. Ryan Lal. Thanks you both for your time today.
Thank you.
All right, Dr. Lal, first question to you. Where should our focus be?
So I would like to first state that my assigned topic was innovation, so I must start with that. However, I think in general, this is really more of a false dichotomy. It turns out that because of processes in place in sort of a capitalist environment, most innovation ends up being cheap to manufacture and then sold for large margins. So as a result of that, we actually don't necessarily need to limit access because most of the innovation we see is cheap. So as a result, I think that we must continue to innovate, but forces will hopefully put us in a place where it is accessible at a cost perspective. That doesn't mean that what it's sold for enables access by any means.
Dr. Gomber, you say without access, what's the point of innovation?
I would still say that because, and I think we'll go deeper today in our session also about why we both stand with access also, but while also standing with innovation. They're not mutually exclusive for sure. We can say they're interdependent, very nicely interdependent. Without access, I think we're just adding failure into our work, because we know diabetes is not just about giving the tools to people, but also making sure it's thinking about the systems that are around them, the social determinants, the health equity piece, and access. The word access in itself is so deep. If you break it down, it has to be affordable. It has to be also who are the actors involved in that space, and also making sure that if we are innovating, everybody should have the same right, which we should. It's about human dignity, right? So if we can actually innovate, making sure that everybody gets the same quality care, irrespective of where they are born or where they basically belong. So I think that's what would be my take on access.
So to go a little bit deeper in that, how big of a problem would you say access to innovation or to technology, how big of a problem is this?
I think it's a big problem. We definitely live in a very disconnected world. I'm originally from India, and for years, I didn't have access to an insulin pump. Wow. Just because I moved my location to a new place where I had a basket of resources to choose from. And that clearly shows that just because someone changed their location, I had insurance coverage, things changed for me. Now I'm at a position I can make the choices for my own care, and that's power. So definitely, if we have to think about power, access is equally important there. Who has the power to give it to you? We have to figure that out. And I'm sure innovation will drive us towards, definitely we have to honor the fact that we've come a long way, but also making sure everybody deserves the same quality care they should get.
Dr. Lal, you're kind of nodding along there. You agree that really without access, innovation is kind of a moot point.
Like Apurva, I had the fortune, my parents are first generation from India, and I had the luck of being born here. So I was born into socioeconomic privilege, which allowed me to always get the best tools. So I've been, using pumps since the early 1990s, and every step along the way, what innovation has really brought me is making the step size easier to get to the goals that we're after. So I see innovation as a way of helping the socioeconomically privileged make the work less, but really helping those who need the access, who need these tools, reach the goals that we're trying to get for everybody. And I think the reality is that who does the technology help the most? The people who have it the hardest. So we really have to focus on making sure that innovation exists, but it's getting into the hands of the people who need it the most.
Great point. Final question to you both, your final thoughts. The path forward is? Dr. Gomber?
I think the path forward is difficult. It takes courage. It takes a lot of hands on deck to make it happen. And I think ADA is doing a lot of work in health equity. Dr. Rehan's doing a lot of work from Stanford around addressing the social determinants. I just want to say to everyone and urge everyone that it's going to be a difficult path, but we definitely need all hands on deck to make this happen, because everyone does hold some kind of power to move the dynamics around, making sure access is available to everybody.
Great point. Dr. Lal?
So I think we currently exist in an environment where the dollar is worth more than a human life. And that is a fundamental issue right now. We no longer have a system where human life is the most precious. It's profits. And as long as profits are driving our decision making around the preservation of human life, we will fail. So until we make that tough decision, as Apurva has alluded to, we are merely going to make more toys for the rich.
Quite a heavy debate topic, and we certainly thank you both for your perspectives today. Appreciate it.
Thank you. Thanks for having us.
Keeping our focus on innovation today, Amarna Therapeutics is a leading gene therapy company that aims to revolutionize the treatment of type 1 diabetes using a cutting-edge gene delivery vector platform. Take a look at how this platform is designed to deliver genes that can restore insulin production in the pancreas.
Our mission is to leverage our groundbreaking non-immunogenic viral vector platform called NIMVEC to deliver not just treatments but potential cures and prevention of disease to patients worldwide. Our lead program, NIMVEC AM510, is poised to revolutionize the treatment of type 1 diabetes by aiming to completely prevent the disease from happening.
If we believe that there is a balance between a bad immune system and a good immune system, what Amana are hoping with their therapy will do is to restore tolerance, which is a good immune system.
You have the potential to cure diabetes and have that as a long-term beneficial impact of that therapy.
And I think it will really transform their lives and make this disease really something that our medical students think, I don't think I've ever seen somebody on insulin. And you go, yeah, that's right, but they used to be.
We hit the floor of the convention center to talk with attendees to find out what you think the biggest issue is right now in diabetes research and care, and how innovation is helping tackle that problem.
As a person living with type 1 diabetes, I think the biggest problem is access to support outside of the doctor's office. We spend 4 hours in our doctor's office a year, and we make about 180 decisions per day related to our diabetes care. The better technology that we have access to, the better we can take care of ourselves, as long as we can get access to it.
Eye care and the awareness for screening of diabetic retinopathy, especially in the developing countries, because now we're able to incorporate AI in detecting diabetic retinopathy.
I think communication is vital, particularly disseminating that information to the public. Many times the complications of diabetes are very horrendous and persons suffer silently. Well, technology can help because everybody has cell phones now, and but then there's some parts of the population that might not be technologically sound or driven. There are still some ways of improving, I would say.
Islet transplant, that's my specialty, and I feel like that is the current need. Apart from that, we need more stem cells. We need more stem cells. There's a cure out there, and it's gonna come sooner than later. Newer sensors are coming out there, yearly sensors are gonna come out. It's going to be a thing of the past.
There's so many little problems we could fix, but the biggest problem, I think, is getting access to all the newer technologies, newer insulin, newer medications to people who could use it the most. Communication, technologies that allow automated insulin delivery, having all that access to data is really going to empower both clinicians and patients to live healthier lives.
Innovation cannot exist without education, and the president of Healthcare and Education, Patty Urbanski, is here in studio to discuss her role as a longtime educator. Pleasure to have you with us today.
Thank you. Great to be here.
Can you start off by explaining a little bit about your role as president of Healthcare and Education?
So my role in the American Diabetes Association is to recognize those healthcare professionals and individuals involved in diabetes who are not physicians, are not necessarily physician researchers, but really represent registered dietitians, registered nurses, all types of diabetes educators, pharmacists, mental health professionals, all of those who are not physicians but still involved in the care of the individuals who have diabetes.
And roles are very important.
Exactly right.
Okay, your presidential address is titled Lessons Learned, Diabetes Education for One and for All. Can you tell us a little bit about what your address will entail?
So I hope to talk about the importance of diabetes education and how when an individual is diagnosed with diabetes, it's such a complicated condition that everyone deserves the right and the opportunity to have a chance to work with a diabetes educator. And therefore we need to work on expanding where we are providing these education services. And one of my main points is that most people receive their care, their health care, in primary care, and we want to work on moving diabetes education out of diabetes education centers and endocrinology practices and into primary care settings.
Do you feel like there is a lack of education when it comes to diabetes treatment and care with regard to those primary care physicians?
Very often, primary care physicians don't realize that there are education services readily available, and we really depend on those providers to sell our services and help people to understand how diabetes education, and we educators can really help them learn about this condition and help them to live more successfully with this ongoing chronic disease.
Right. We're focusing on innovation today. How would you say diabetes education has changed over the course of your time as an educator?
Well, just since the pandemic, certainly telehealth and telemedicine visits has become a great addition to the services that we are able to provide and has really opened up access to many people. So learning how to best offer those telemedicine services is certainly something that we need to be continuing to work on, as well as the use of diabetes technology, particularly continuous glucose monitors, and educators can play a main role in helping people use this technology, understand the technology, learn how to interpret what they can learn from that.
You know, you've held a lot of positions over your incredible career. Does anyone stand out to you, or any particular role stand out to you when it comes to having the biggest impact on diabetes?
Well, I have to say serving as president has certainly been very rewarding, and it's been very fun to see the inside operations of the American Diabetes Association and to really appreciate the impact that the ADA is trying to have on the lives of individuals with diabetes, whether that be supporting research, looking for a cure, and improvements in treatment, advocacy issues, as well as providing education services to those individuals.
And we should point out you are halfway through your term as president.
I am.
Everything going well, going smoothly?
So far, so good. It's been great.
Well, best of luck in the next 6 months, and we certainly look forward to your presidential address.
Great, thank you.
In today's healthcare environment, technology is playing a crucial role in improving patient care. Ochsner Health is leading the way with a transformative digital medicine platform that's revolutionizing diabetes management.
Ochsner is actually a not-for-profit integrated health system founded in 1942, so we've been around for over 80 years at this point. The program was really built over 9 years ago as an internal quality initiative. Really what we built was essentially a specialist that our primary care providers can use to send their patients to better manage conditions like hypertension and diabetes, just as, or better than, frankly, we would do in a clinic or in a primary care setting. The end result was that we saw such great outcomes that from there it just started to grow.
The real impact of digital medicine is that we have shown that we can improve the quality of care while reducing the total cost of care. For our patients, it really means that we've been able to meet them where they are and provide them high quality care in a way that's convenient for them.
These solutions are patient-centered solutions, which are not only the right solution for the patient, but they're also great solutions for the provider as well.
Now to a quick announcement. Be sure to wear red on Sunday. We will all be rocking the red on Sunday, June 23rd to show our support of the ADA and our mission to improve the lives of all people affected by diabetes. Together, we can achieve a world free of diabetes and all its burdens. Red merchandise is available for purchase at the Shop Diabetes store, and remember, every purchase supports diabetes research, advocacy, awareness, and educational programs. With that, we wrap up day 2 here at the American Diabetes Association's 84th Scientific Sessions. We hope you've enjoyed today's content, and if you missed any part, or you loved something so much you'd like to see it again, remember, you can always find the latest ADA TV episode on our TVs placed throughout the Convention Center, on the in-house channels at several of our partner hotels, on the shuttle buses to and from the venue, on the ADA Scientific Session website, and on our X and YouTube pages. We are only halfway through this exciting week, and we look forward to seeing you right back here tomorrow on ADA TV. Until then, have a great day.